Okay, scenario here. In the middle of the night and your care aide calls you. The patient in room 12 is acting really weird. You walk in and there she is, confused, agitated, pulling at her IV. But she was completely fine 2 hours ago. You know what? This is one of the most common and most dangerous situations you face on a medical surgical floor. Let me walk you through exactly what I can do or what I would do. Before anything else, you want to check, is she breathing? Is she safe? Are the bed rails up? Is core lighting rich? Then I'm going to go straight into checking the patient's glucose. Every single time you want to check the glucose first. Because hypoglycemia is fast. It's reversible, but it mimics everything. So you want to rule it out in 10 seconds. And if that's the cause, you fix it before you even call the doctor, right? Because that's the best thing to do. You don't want to call the doctor and be like, oh, the patient is confused and what do you want us to do? No, you call the doctor, you tell him the patient is confused. I check the sugar, is this and that and that. I'm thinking this or that. Okay? So now that you've checked the patient's sugar, while checking the sugar, you should be having a second plan. And that is, what if it's not a hypoglycemia problem? Okay? What if it's not hypoglycemia? But one thing you need to know is that medical surgical floor, specifically, I'm just going to narrow it down immediately. When there's new confusion in a hospitalized patient, it means three things until proven otherwise. One, glucose problem. Two, infection. Or three, medications. So medications like your opioids, your benzos, anticholinergics, you need to check when last the patient was given those medications. Was it given in the last 6 hours? You need to check for that. And here is where experience kicks in. Now, you check the glucose and it's fine. So what do? I'm going to pull up the patient's vital signs, and her heart rate is going to be what? You notice that the heart rate has been quietly climbing for 4 hours. There's low grade temperature, slightly elevated respiratory rate. So, new confusion, I am now thinking of sepsis if it's no glucose problem. And here is what I want every new nurse to hear. In elderly patients, especially women, a UTI will present as nothing but confusion. They wouldn't say there's dysuria, there might be no fever, just suddenly them not being themselves. So if you notice all these, you need to start thinking. There might be some UTI brewing somewhere. Now, when I call the doctor, I want to go with the S bar. So I'm talking about situation, background, assessment, and recommendations. So when I call the doctor, I'm not going to say, it seems that she is a little confused, but I would rather say, my patient has a new acute change in mental status. There's a rise in heart rate over 4 hours. There's low grade temperature. I'm concerned for early sepsis, and I'm requesting maybe a sepsis workup. Or what do you think? So, you frame it in your own way. You frame it in such a way that you advocate for your patient. And that is our job as nurses. So, just note this: confusion is never just confusion. So, if a patient is confused, don't just say, oh, the patient is just confused. No, it's rather a red flag from your patient's body. It is signaling you something. It is telling you that there's something going on. So you first need to think of glucose. Is it hypoglycemia? Think of infection. Check if there's been trends in the patient's vital signs. And trust yourself at 2 a.m. If something feels wrong, work it up. Because that instinct is what keeps your patient safe.